So welcome to this lecture on choosing appropriate phosphate binders in young CKD adult patients on chronic hemodialysis. My name is Jürgen Flöger. I'm from Aachen, Germany. We know from observational studies like this one that there is a range of phosphate where the mortality is lowest. This is patients, more than 10,000 patients from the European Fresenius database. And you can see that no matter how you correct and what you adjust for, the lowest risk zone for mortality is about 1.8 to 1.1 millimoles per liter. If you live in a milligram per deciliter country, please multiply by 3. But that's an association with a single time point. More telling is this study where we looked at the Cosmos cohort. It's a hemodialysis cohort, non-interventionally followed, and we looked at the following. If the patient had a controlled baseline phosphate, what would happen if in the next 6 months the phosphate shifts upwards? Well, mortality increased. If it shifts downwards, mortality increases. And note that this is adjusted for albumin, so this is not malnutrition. But here's the telling situation. If at baseline our patients had hyperphosphatemia and the phosphate increases even further during the next month, mortality increases. But if it decreases, mortality decreased by about 20% unless it decreased very much. And it's really terrible to say that in the year 2015, this was one of the first bits of evidence that treating hyperphosphatemia is beneficial. We need a good intervention study, and one is just ongoing now. About 50 years after dialysis was invented and came to clinical use. Another study that suggests that phosphate control is important for patients is this Japanese study. They originally wanted to compare lanthanum and sucroferric oxyhydroxide in terms of coronary artery calcification progress. And maybe it was slightly lower here, but the difference was not significant. But they also had a standard treatment and a strict phosphate control arm. And what you see is that the strict phosphate control, at least in Japan, worked. I love Japanese patients. They do what we tell them. And they had a lower phosphate over the 12th month of the clinical trial. And look at this. Calcification progress was much lower in the patients on a strict phosphate control. There's also different types of phosphate, and probably the worst is phosphate additives, because these are salts and we all absorb them 100%. And the food industry puts phosphate salts into many, many foods, some of which you wouldn't even think about, like coffee whitener, or they sprinkle it on cheese. Lots of things contain phosphate salts. So here's a study in 10 healthy volunteers, 1 week diet with 900 milligrams of phosphate and no additives, and 1 week diet containing mostly processed food. This is what happens. The calorie intake was identical and the food composition was identical. But look at this. Phosphorus intake increased by 60%, and sodium intake almost doubled in the patients consuming mostly processed food. So it makes a huge difference whether you buy a pizza ready to go or whether you make the same pizza yourself with fresh ingredients. And these are absorbed, both the sodium and the phosphate. Now, when you talk about phosphate binders, something we often ignore, that is age of the patient. My typical patient is 75 or older, and the life expectancy of that patient is around 1.7 years. In that patient, I simply do not care about phosphate as long as it's not excessive, because I want these patients to eat, I want these patients to enjoy life, and I want these patients to move. The situation is totally different in a young patient. Let's say a 30-year-old on dialysis. You want to give a transplant to this patient, and you want to transplant to a good, well-preserved artery and not a rock. So I would do everything in a young patient to prevent progression of calcification. And clearly that involves phosphate binders. Now, phosphate binders are a problem. The daily tablet load in dialysis patients is one of the highest of all chronic patients. Dialysis patients consume on average 19 tablets a day, 19 tablets. And half of them are phosphate binders. And the phosphate binders are big. And you immediately know, and everybody knows this, patients don't like phosphate binders. Many phosphate binders are large pills. This is why in the old days, my patients liked aluminum hydroxide because it was small, easy to swallow, and they liked it. Unfortunately, we learned that it can accumulate in the brain. And you see that there are many others, and the size increases as you go along. Sevelamer is relatively large, just like calcium acetate. This is a chewable tablet, and you have to chew it a lot. And sucroferric oxide is also a chewable tablet, but in contrast to lanthanum, it dissolves very quickly. Why do patients not take phosphate binders? In Wales, they asked 919 patients, 25 admitted they have problems. 38 admitted they forget it at least once per week. And they forget it because they forget. The size is too big. They have swallowing problems. Don't underestimate that. Many patients on dialysis have dry mouth. Many claim that there are too many. They have chewing problems. Many patients have bad teeth. The taste was not nice. And this is really strange because all phosphate binders are effective if you take them. Here's a summary that I made for a review article some time ago, and clearly all phosphate binders are effective. The pill burden is low with aluminum, high-ish with calcium and sevelamer, low with lanthanum, calcium, magnesium higher, cholesterol is like sevelamer. There are pleiotropic effects in sevelamer and cholesterol. It's nice that they lower LDL cholesterol and uric acid. It's not so nice that sevelamer also binds vitamin D, vitamin K, and thyroxine. There's accumulation of calcium and aluminum potentially. Lanthanum can deposit in the submucosa of the GI tract. And cost obviously is an important consideration. Now, if you look at the KDIGO guidelines, and the latest update is still from 2017, it will be updated soon. But in 2009, they said, we suggest restricting the dose of calcium-based phosphate binders if there is arterial calcification. And I never understood this guideline, never. Because why wait for calcification to occur and then do something? This is why 2017 is much nicer, I believe. We suggest restricting the dose of calcium-based phosphate binders. Now, there are two new phosphate binders around, ferric citrate and sucroferric oxyhydroxide. They're both effective. Pill burden is high here, it's very low here. They have no pleiotropic effects. Ferric citrate can accumulate and in fact lead to iron overload, probably because of this citrate component, which opens gap junctions in the gut and allows iron uptake from the gut. Sucroferric oxyhydroxide doesn't do this. There's a little bit of iron uptake, but very little, and no case of iron overload has been reported, and cost can be an issue.